Welcome to the crash tutorial on how to use Fair Choices DCP analytics tool. I'm Kjell-Arne Johansson. I'm a professor in Bergen Center for Ethics and Priority Setting and lead the Fair Choices tool development. I would start from our webpage, fairchoices.org, and I would go through some pieces of information we have on the webpage. You can get guidance on the methodology, explore some training materials and others, and you can access the tool, probably the most important thing, by clicking this link here. Then the web-based Fair Choices version will open up. This is the introduction tab. You start by clicking, choosing the country you are interested in. I will, in this tutorial, use data from Ethiopia. And to load the data from Ethiopia, I usually go to the benefit package, and then we will upload the data for the Ethiopian analysis. This icon here shows that we're now pulling down data from the 4 computers we have in Oslo, and now they are loaded. Here you see the decision tree with all the interventions, but we will go back to one of the previous tabs first. Fair Choices is organized around this list of tabs, and each tab has a separate function. We can start by looking at the disease burden tab. Every tab has an icon where you can get more information about what variables we have here, where we have data. And as you can see here, all epidemiology data we use in the template in the analysis is downloaded from the GBD study. And it's a very simple table compared to what you find at the IHME site, but it's useful information, so you can quickly get the information about the disease burden and what are the main killers. Now I rank ordered interventions by the total number of deaths due to the conditions you see on the condition row. Neonatal disorders, cardiovascular diseases, and enteric infections are the main killers in Ethiopia, and if you want to have an impact on those, you need to select interventions targeting these diseases. You can also get information about total incidence and prevalence, and if you really want to deep dive into epidemiology, you can go to the epidemiology tab. But first, we will now move to the budget space analysis, where you can make a more informed decision about how much resources would you expect to have available in the forecasting horizon that you look at the benefit package. And here it's from 2021 to 2031. This is Ethiopia, and you can adjust the variables, and it's important when you adjust variables, you do this in a very good dialogue with the Minister of Finance and the Minister of Health, and involve experts that know what is what to use as input. So you can change what you expect of the economic growth. It can be low, it can be high, and this will of course influence how much you have in the future. We can assume for now it's 4%. You can also adjust the baseline funding source. And we see here that red, that's the government spending. Green is the donor funding. Dark blue is out of pocket, and the turquoise is the health insurance. And if you adjust these variables, you can see that the whole analysis changes. We can assume that in Ethiopia, 20% of the budget comes from donors, maybe 30% comes from out-of-pocket expenditure, and maybe you have, let's say, 4% coverage of health insurance, and also maybe the government spends maybe around 1.7% of their GDP on health. So these are the baseline input variables, and then economic growth, of course, is important, but you can also then say, you want a more ambitious government. You want them to maybe spend 2.2% of their GDP on health, and you saw how that influenced the forecast. you can maybe we can assume you will get 2% less from donors over the next 10 years. Maybe you want to reduce out-of-pocket expenditure to 7%, and maybe you want to increase health insurance to 10%. And based on these input, you get the following fiscal space analysis. You can go from baseline budget today, where it's $31.6 per capita, and maybe you want to then aim for 48.9 in 2031, or over the next 10 years. So that would be around $16, $17, but let's assume you have $15 per capita. You can increase the health budget over 10 years. But of course, again, this needs to be done with experts and in collaboration with Ministry of Finance and Ministry of Health, and in good processes. If we then move to the benefit package, you can see that we have a tree where we can visualize all the interventions, and we have around 20 clusters of interventions. You can see all interventions are listed in the table below. We have around almost 500 interventions in the analysis, but we only analyze around 400 of these, I would for now. But if we then look at the details on how this is structured, so if you click emergency care, you get the following sub-interventions in emergency care: first aid, emergency care basic, emergency care advanced, acute orthopedic management. And you can see then only these emergency care interventions are displayed in the table below, with information about ICER, cost and health benefits, baseline coverage and target coverage. And we can then give 100% target coverage to these. That means you would go from the current baseline coverage that seems to be very low in the input now, and you could then achieve 100% coverage in this analysis and the information here. Then you can see the cost for each single intervention, and the emergency care basic, it means management of non-displayed fractures, resuscitation, triage and stabilization with referral, and you even give priority to emergency care, advanced trauma laparotomy, tube thoracostomy, intoxication management, acute intracranial pressure relief, and also the acute orthopedic managements. These sub-interventions can also be displayed in the tree like this, but you don't get any information. The information is best shown here, where you get information. The most important column is then probably the ICER. That means incremental cost effectiveness rate. So then you divide the 10-year cost of the intervention by the healthy life year. So this is the cost per healthy life year. So when it says 635.8, that is the cost for one healthy life year if you invest in the first aid, if you invest in the whole emergency care package. But then you can get more detailed information for other packages as well. Emergency care advanced, it has an ICER of 491.96. And within this cluster, it seems like this intervention is the most cost effective, and that is the tube thoracostomy. That has a cost effectiveness rate of 64.3. So if you want to change priorities according to the cost effectiveness, you would best do that in the league table. But if you want to go back to, if you want to change another intervention, you can choose cancer. And you can see for now we have only cancer detection, cervical cancer, breast cancer, colorectal cancer, and early stage childhood cancers. And again, you have more information about the interventions at lower levels. We could then only prioritize we can prioritize the whole the whole cancer package to 100%. That means you go from the baseline coverage that we have in this table here to 100%. This would be the 10-year cost. This would be the 10-year healthy life year benefit. This would be the 10-year life year benefit, and this would be the 10-year life saved benefit, and this is the under 5 mortality benefit. And again, the ICER column is the most important, where you can see that treatment of early stage cervical cancer seems to be the most cost-effective package of the adult cancers, with $66.72 per healthy life year. But if we go to the early stage childhood cancer, this is more cost effective. The whole package has a cost effectiveness of 94, but the treatment of Burkitt and Hodgkin lymphoma and treatment of acute lymphoblastic leukemia have low ICERs, but kidney tumor or Wilms tumor is has a less beneficial ICER, and it's at $560.4 per healthy life year. So in order to go back, you can close this, but then you can, if you want to analyze impact of scaling up all interventions, you have to just close the whole tree and open it again, and you will then be placed at the foot of the tree, and you can see all the interventions in the table, and you could set target coverage to 100%. And we can then go back to the program summary and see what would be the consequences of giving priority to all services. That means going from baseline coverage to 100% coverage of all services, and then you basically have universal health coverage in Ethiopia. The cost for this program this benefit package would be $47.4 per healthy life year, and this is way above what we agreed on, or what I showed in the fiscal space analysis earlier. Then with the input we had, we could only increase the health budget with $15 per capita. So it's not a sustainable package. This would be the total cost over 10 years, and this would be the benefits over 10 years. And you can also get information for each program. You get information for the 10-year cost, the healthy life years, life saved, under 5 mortalities averted, and the ICER for the whole package. And we can sort the more programs by their cost effectiveness, and we can see that it's maternal and newborn health. That's the most cost effective package, and that's at 48.2. And child and adolescent health, the second most cost effective package, it's at 54.8, and HIV and STIs at 136. This is also information about cost. And you can see in this version now we have some interventions with zeros. And then that is basically because we think these interventions are too important to be left out. But at the moment, we have not had capacity to analyze those. So you will see zeros when you look at these interventions in the league table. But for the interventions in the other programs, we have done analysis. But since we now see that you can not afford this package, we need to try and make a feasible package, and we then can start from scratch going back to the benefit package. And now we stand at the root of the tree because we see all interventions are listed below in the table, and we can click no change. So what an alternative approach to setting target coverage is to go to the league table. And then you have a figure where you have information about the ICER, the cost effectiveness of all the interventions, and also severity that I can come back to later. So each intervention has a red dot, and you get information both about the severity of the disease and also about the cost effectiveness, and you can explore this trade-off. And again, remember, if you want to know what this figure is about, you can click on the figure, and you will be hopefully smarter. And if you don't understand this, please send us an email. And here you can get information about the league table below. And here we have all the interventions that you can analyze in Fair Choices, also including the intersectoral rehabilitation, pandemic preparedness, the interventions that we currently have not analyzed in Fair Choices. But the benefit with the league table is that you can rank order interventions. And now I just clicked on this column, the ICER, US dollar per healthy life year, and you get the most cost-effective interventions at the top and the least cost-effective interventions at the bottom. And we can see that it's the maternal neonatal child health interventions that are the most cost-effective interventions, and they have ICERs more or less below $100 per healthy life year. And you could then, if you have $15 per capita that you could increase the health budget, we could maybe stop at the willingness to pay threshold at $100 per healthy life year, and then all these interventions would be what you could afford. And you now saw I tagged all these interventions by just clicking at the first one and then holding down Shift, and I clicked down to 91.488 because that was a hypothetical willingness to pay threshold. And you can give this a 100% target coverage because these interventions are very cost effective. There is one tweak here in the league table. If you want to set the target coverage, you have to click twice. And we're very sorry for this hassle, but that's how far we got. And then if you want to know what you prioritized applying the health maximizing principle, you would then get a budget where you could increase, where you will increase the health. It's estimated that you will increase the health budget by $4.13 per capita in the end year of the period. So that means you're still below the $15 increase that we agreed on in the, or I just agreed with myself on in the fiscal space analysis, so we can afford more. And then we can go back to the league table, and since I mentioned the healthy adjusted age at death metric, we can try to rank order the interventions by the severity of the conditions that they target. And you see, you get information. So this sickle cell disease has a HUD of 9.8, and acute lymphoblastic leukemia has a HUD of 20.6, and so on. And that basically means that the average health adjusted age at death for those conditions that are affected by the interventions are at 9.8 and 20.6. And if we look at some of the interventions with a high HUD, that would be more, that would be interventions that affect old people. And then, for example, you have dementia care that has a healthy adjusted age at death at 71. So then what we could do, if you want to give some weight to worse off, you could then click, I will remove this one again, and you basically just include them and exclude them by clicking them. So when they're blue, that means they are in your focus. So we could maybe set a severity threshold at around 60, maybe we can set it to 64 here, and we include, that means self-management treatment of migraine is the last intervention that will be given priority because these interventions affect conditions with a health adjusted age at death less than 64. And again, we can give 100% coverage, and we need to click twice. And we go back to the program summary, and we see how far we have gone with the budget. And now we increased it to $19 per capita. So either you have to go back and change your priorities, or you have to go back to the budget space analysis, discuss with the Minister of Finance if you could afford to increase the health budget to $19 per capita. And now you see this table here is relevant because we gave priority just according to HUD and cost effectiveness, but that means you will invest in some interventions that are not the most cost effective interventions. So this shows how much health you lose by investing in interventions that are not the most cost effective interventions. So this is the cost of adding equity concerns in your priorities and in the benefit package. So that means you will lose 2.5 million healthy life years in 10 years if you invest $19 in the benefit package you have. So it's not the most cost-effective package, but maybe it's a fair package because you have both taken into account cost effectiveness and severity in your priorities. You can also work manually, and that is probably useful when you will work with the programs. If you want to work with the malaria program, you could then look at the interventions you have in the malaria program, and maybe you want to really do a deep dive, and then you have indoor residual spraying, malaria chemoprophylaxis, and so on. And this is information about baseline coverage. And this is the target coverage that you have set with the rank ordering interventions by cost effectiveness, having a willingness to pay threshold at 100, and rank ordering them by HUD and giving priority to the most severe conditions with a HUD less than 64. But maybe they would want to give some priority to, or they can maybe do it manually. Maybe they want to give some priority to all these comprehensive management of severe malaria. Then you can add those to the program by just clicking 100% when you're standing in the tree here. Maybe you even want to include the malaria contact tracing. You can give it 100%. And then maybe you go to the cancer team, and then you have someone in the cervical cancer team. They want to give everything 100%, and then you stand in the node and give 100%, and you can see how this influences your total cost. Then you go to the program summary, and it didn't have much impact, but still you're over your $15 per capita threshold. So you need to remove something, or you have to increase your budget. We have a bookshelf plot. I will not talk detailed about this. You can read the instructions here, but it's basically shown in rank ordering interventions by their cost effectiveness, where the most cost effective interventions are to the left, the least to the right, and the width of the bars indicates the budget impact. And you can zoom in on interventions, and you click on the intervention and you get information about what those interventions are. So that's the bookshelf plot, and you can get information about cost and effects by delivery platforms. So this is these are the consequences of your benefit package that we now have prioritized, where you can see that the major benefits and cost of these services are at the primary healthcare level at the health centers. And that's probably because these interventions are the most cost-effective interventions, and that's where you scale up these interventions. But you also have some population-based interventions, and you have some interventions at referral hospitals. And you can print all these charts, you can view them in full screen, and you can download them if you want to use them in a PowerPoint or a report. And interestingly, we also have a demographic analysis where we now analyze the total impact of the benefit package that we have created. And we can look at what is the expected impact on life expectancy in Ethiopia by the benefit package we have now given priority to. And then if we look at, you have different pieces of information in the demographic plot here. But if we look at the life expectancy plot, we can open this in a full screen, and we see that the life expectancy in Ethiopia today is 67.5. But if you scale up interventions, you will have a life expectancy of 72.8 in 2030, and the UN Population Division estimates is at 70.2. So you go from 67.5 to 72.8 in life expectancy in Ethiopia if you can achieve the targets you have set now in your benefit package. We also have some information about births, and you can change the input on births by going to the settings, and you can scale up the contraceptive met need. If that's 40% now, you could increase this to 80%, and you could look at how that would influence your demographic plots. And then you need to calculate an update. And you can see here on these pyramids that the population in the 2031 estimates, you have a lower less people in the younger age groups in 2031 compared to 2021. So that would be the impact of scaling up contraceptive and family planning. And the others, you can read about these in the instructions that we have downloaded, and more videos will come. This is just a crash course on how to use Fair Choices, and I would not recommend you to use this tool alone. I would highly advise you to work using this tool in collaboration with BCEPS, because then we can together develop analysis that maybe you would want to have in your setting together. We can work on parametrizing the model with better data input, because you would need to have, maybe you want to have better data on costing, maybe you want better data on epidemiology, maybe you have better data on baseline coverage. Those are the three most important sets of parameters where we would need to work together, and we can populate and parameterize the model together. Good luck with using the tool, and good luck with the rest of the course.